Welcome to The Explainer. Today, we're diving into Spain's big clinical guide on bipolar disorder. We're going to distill it all down to the essentials, the stuff you, as a future health professional, really need to know about diagnosis, treatment, and what the future might hold for your patients. So let's get right into it. All right, so here's our game plan. We're going to follow a really logical path. First, we'll nail down exactly what bipolar disorder is. Then, we'll trace the steps to a solid diagnosis. From there, we'll look at how to handle those acute crisis moments, then shift to the long game, achieving stability. And we'll wrap up by talking about why you absolutely need a holistic, whole-person approach. Okay, first things first. We have to define bipolar disorder. I mean, before you can even think about treating it, you have to have a rock-solid understanding of what it is and who it affects. So, at its very core, the guide calls bipolar disorder a serious, recurrent, and lifelong condition. And the key words here are recurrent and lifelong. It's not just about being moody. It's about these distinct, profound swings in mood, episodes of mania or its milder form hypomania that alternate with deep depressive episodes. These aren't just feelings. They dramatically affect a person's life. And this distinction right here, it's absolutely fundamental. For bipolar I, the defining feature, the thing you have to have, is at least one full manic episode. Bipolar II is different. It's marked by those less severe highs, which we call hypomania, but, and this is critical, it also requires at least one major depressive episode. Getting this right isn't just about a label, it changes the entire playbook for treatment. And just to give you a sense of the scale we're talking about, the lifetime prevalence for bipolar I is around 1.6%. And remember, that's just type 1. When you start to include the whole bipolar spectrum, that number goes up. The takeaway? As a clinician, it's not a matter of if you'll see patients with this condition, but when. So how does someone go from just having some symptoms to getting a confirmed diagnosis? This journey is so important, and funnily enough, it often doesn't start with a psychiatrist. It starts in a primary care office. The whole thing kicks off with what we call a high index of suspicion. The guide really pushes primary care docs to not just see depression and stop there. You have to ask the right questions, actively screen for any history of mania or hypomania. If any red flags pop up, that's when you make the referral for a full-on specialized assessment to really get to the bottom of it. Now, this specialized assessment, it's not just a quick quiz. It is a deep dive. We're talking a full clinical and family history, mapping out symptom patterns, looking at how the person is functioning in their daily life. And here's a huge piece of it: screening for other conditions that often ride along with bipolar disorder. And the guide could not be more clear on this. Comorbidity is enormously frequent, and its management is decisive for the clinical course. So what does that really mean? It means things like anxiety or substance use aren't side issues. They're central. You have to identify them and treat them. It's absolutely critical for the patient's long-term outcome. All right, let's shift gears. Now we're talking about managing the storm, the acute episodes. When your patient is in the middle of a full-blown manic or depressive crisis, what do you do? What are the strategies that actually work to get them safe and stable? You have to realize the goals here are complete opposites. In a manic episode, the priority is to get a handle on the agitation and any psychosis. So you're reaching for antipsychotics and mood stabilizers. But in a depressive episode, the goal is totally different. You've got to relieve the depression without accidentally flipping them into mania. That risk is so real that it comes with a major clinical warning. For acute mania, the guide points us to a class of drugs called atypical antipsychotics as the first line of defense. Medications like these: risperidone, olanzapine, quetiapine, aripiprazole, they all have solid evidence behind them. They work fast to bring those severe symptoms under control, and you can use them alone or combined with a mood stabilizer. Okay, lean in for this one. This might be one of the most important takeaways for any student. The guide gives this a grade A recommendation. You do not, I repeat, do not use an antidepressant by itself to treat bipolar depression. Why? Because the risk of triggering a switch into mania is just way too high. This is a massive difference from treating regular unipolar depression. So once the crisis is over, the goalposts move. We're not just trying to put out fires anymore. The new mission is long-term maintenance. It's all about preventing that next episode from ever happening. In this maintenance phase, mood stabilizers are your bread and butter, but they aren't one size fits all. You've got lithium, which has been the gold standard forever, and it's especially great at preventing future manic episodes. Then you have something like lamotrigine, which is much better at preventing depressive relapses. So for a patient whose illness is mostly depressive, lamotrigine is a key player. But listen, meds are only half the battle. Psychoeducation is just as vital. This is all about empowering the patient. You're giving them the knowledge and the skills to understand their own illness, to stick with their treatment, to spot those early warning signs of a relapse, and to build a stable, healthy life. It turns them from a passive patient into an active partner in their own care. So with all these amazing tools, you might be asking, what's one of the biggest hurdles in long-term treatment? Well, the guideline is very direct about this. It's non-adherence. People stopping their medication. It is the #1 reason for relapse, period. And that brings us perfectly to our final and maybe most important section, the need for a truly holistic approach. You can't just write a prescription and call it a day. Effective care for bipolar disorder is about treating the whole person. And really, nothing captures this holistic view better than the nursing care plan. Just look at the scope of this role. It goes so far beyond just meds. It's about monitoring physical health, managing stress, helping the patient become more autonomous, supporting their family relationships, even coaching them on life skills. This is what real patient-centered care looks like. But even the most perfect clinical plan can be completely derailed by stigma. This quote, this comes directly from a patient who was consulted for the guide, and it is such a powerful gut punch for all of us. The feeling of being treated differently, even by other doctors and nurses, is real, and it is so damaging. And so that leaves us with this final challenging question. The guide gives you the clinical tools, the playbook, but the bigger challenge, the one that's really going to define your generation of care, is this one. How do we build health systems that actually support recovery? And how will you, in your own day-to-day practice, fight back against the stigma that patients face? That's the thought I'll leave you with. Thanks for watching The Explainer.